Hello. Hello, hello. हेलो।
हाँ आकाश।
हाँ जी, कैसे हो भैया?
बहुत बढ़िया। तो मुझे को होस्ट बनाया। आकाश।
बना दिया आपको कॉस्ट। मैं कह रहा था पहली प्रेजेंटेशन मेरे को ही प्ले करनी है ना?
हाँ फर्स्ट वाली प्रेजेंटेशन तैयार रखना, जैसे ही वो इंट्रोड्यूस करेंगे तुरंत वो प्ले करनी है, ठीक है?
या फर्स्ट नंबर और थर्ड नंबर?
हाँ फर्स्ट नंबर और थर्ड नंबर।
और
ठीक है।
टाइमर जब 30 मिनट का मैं स्टार्ट कर दूंगा।
हाँ हाँ टाइम स्टार्ट कर देना, वैसे वो जो है अंडर टाइम ही है जो प्रेजेंटेशन।
अच्छा अच्छा, ठीक है, कोई दिक्कत नहीं।
ठीक है। तो डॉक्टर पहली वाली जो है स्लाइड है उसका आप जैसे मतलब इंट्रोड्यूस कराएं, वो आप स्लाइड खोल लेना, मतलब पॉज करके जो है जो फर्स्ट स्लाइड है ना,
बिल्कुल बिल्कुल, कोई प्रॉब्लम नहीं।
टेन पे क्लिक करो।
ठीक है।
और कोई भी आएगा तो उनको एंट्री देते रहना, क्योंकि ये तो फर्स्ट एक ही सेशन है, तो सबको एंट्री दे देना एक साथ।
अच्छा हाँ ठीक है, सबको एंट्री दे दूंगा। और पोस्ट किसको बनाना है इसमें? किसी को और को बनाना है पोस्ट?
नहीं नहीं नहीं, मैं
ठीक है ठीक है।
और हाँ डॉक्टर पंकज पुरी आएंगे, उसको बना देना।
ठीक है ठीक है।
नाम आएगा, नाम पे दबाओ और इनवाइट करो।
Rahul, can you hear me?
Yes, sir. Hi. I can hear you, sir.
Can you check the bandwidth?
Akash, please check the bandwidth.
Yes, sir.
Can you
Hello?
check the bandwidth?
Yes, sir. Yes, sir. Your voice is clear.
Yeah, bandwidth speed is fine, na?
Yes, yes, yes. हाँ, स्पीड फाइन है.
ठीक है, thank you.
Welcome, sir.
Hello, sir. Hi, Dr. Sudhanshu. How are you?
Hi, Pankaj.
Hi, sir. How are you? Good to see you. I think we have another 5-7 minutes. I think others will soon be joining, I guess. So I was just thinking, sir, the talks are 13 plus 2 minutes each. In 2 minutes, we'll not be able to have any meaningful discussion. So it's better to finish the talks and add that 8 minutes in the end. So if there is going to be some meaningful discussion, it is better to do it at the end.
Yeah, I think that is better.
Better.
Because anyway,
Hi, sir.
two of the speakers won't be there. Am I right? It's a video presentation.
So it's better to do all the discussion in the end.
सुधांशु भाई नमस्कार. आप अनम्यूट हो. अनम्यूट करो अपने आप को. म्यूट हो. म्यूट.
यस. कैसे हैं?
बस जिंदा हैं.
जी. ऐसे मत कहो.
नहीं प्रॉब्लम है. Actually what I should have been in my studios in Cuttack. My daughter had acute appendicitis, was operated, so I rushed down to Pune. I'm in Pune now. पंकज पुरी के शहर में हूँ.
सब बहुत सुंदर शहर है सर. अभी ओनली थिंग तो वहाँ पे कोविड कम हो गया, तो अदरवाइज तो पागलपंती थी.
So
कहाँ, where has she been operated in Pune, sir?
भारतीय विद्यापीठ.
भारतीय विद्यापीठ. बहुत सारे एक्स फौजी गैस्ट्रोएंटरोलॉजिस्ट हैं, 3 तो हैं कम से कम.
कौन?
वहाँ पे सर नागपाल है, दुहन है.
वो दुहान यहाँ है.
हाँ.
मैं ढूंढ रहा दुहान कहाँ गया. वो जब देखो किसी पहाड़ पर चढ़ रहा था.
आई नो. और एक और है.
वो असली फौजी है वो.
नहीं.
Not that you are a नकली फौजी.
I know, sir. जिंदगी जीना नहीं सीखा सर. Hi sir, how are you? Good to see you. Hi Dr.
हाय समीर.
दीपिका अपने को अनम्यूट करो.
कर दिए.
कर दिया.
हाँ. हेलो.
हाय.
हेलो, कैसे हैं दीपिका?
बढ़िया. आप कैसे हैं?
बढ़िया है. गुजराती इज फाइन. मच बेटर फॉर कोविड.
Yes. It will be so wonderful if we could all meet up, but उपाय नहीं है.
I know. I'm actually missing all the meetings.
Yeah.
Getting to physically meet people was a joy. Yeah. We underestimated the value of all that.
Chatting with everybody in between conferences.
True.
I am a classical case of outstanding delegate, so I am missing.
But you are not a stalwart.
नहीं स्टॉलवर्ट में नहीं हूँ.
स्टॉलवर्ट में नहीं है.
स्टॉलवर्ट नहीं.
अच्छा, ये तो ज्वाइन ही नहीं किया अभिजीत चौधरी.
तुम उसकी चिंता मत करो.
अभी है सर, 5 मिनट है सर, लेट एंट्री होंगे.
नहीं, अभी क्या किए ना वो लोग, वेस्ट बंगाल चैप्टर का आईजी का मीटिंग सेम टाइम पे रखे हैं. अभी 6:30-7 बजे से वो मीटिंग चल रहा है. वो भी एसएसकेएम हॉस्पिटल में फिजिकली मीटिंग चल रहा है.
वहाँ कोई आईएसजी नहीं है. तुम्हारे बंगाल में देयर इज नो आईएसजी, देयर इज ओनली
आईएसजी. हाँ, वेस्ट बंगाल. और ऊपर से हम जब बोल रहे हैं वांट टू बी इन द कमिटी बिकॉज न्यू कमिटी इज गोइंग टू बी सिलेक्टेड, नोबडी इज बॉदरिंग टू आंसर माय मैसेजेस और फोन कॉल्स. हम लोग का बहुत बुरा हालत है कलकत्ता में. Because I told them INSL is starting, please change the date. Nobody is bothering to answer their messages also. मैंने WhatsApp में लिख रहे हैं, उसका आंसर ही नहीं कर रहा कोई. So they knew INSL was on this date. They should have had it another date, ना?
देखो इस चीज पर मैं अभी कुछ नहीं कहूंगा, मेरे बहुत स्ट्रॉन्ग व्यूज हैं। ऐसे ही जर्नल ऑफ हेपेटोलॉजी ने मेरे को ऐसा लिखा है
हाँ,
कि मैंने जो लिखा है उनको एक लेटर टू एडिटर,
हाँ,
उन्होंने उसको डिस्क्राइब किया एज अ पैशनेट रैंट। योर पैशनेट रैंट इज फिट फॉर अ फायर ब्रांड जर्नलिज्म,
ओ,
उन्होंने लिखा है।
अच्छा.
इसलिए मैं कुछ नहीं बोलता।
But I don't understand. I mean, when INSL, a national conference is going on, they want to do ISG West Bengal chapter meeting at the same time, that to physical meeting. And then they're selecting the new executive committee also. So I've written very strongly many times that I want to be part of the meeting, because every time they do it on a festival day when I can't attend. They'll do it on a Rakhi, or they'll do it on some day when you can't attend. I don't know. अभी तो चल रहा है मीटिंग, अभी अभिजीत चौधरी तो गायब है. I've kept asking him, are you attending are you going to be here or not here? Not answered.
नहीं, छोड़ो, फिर मैं कुछ नहीं बोलूंगा, छोड़ो।
आप नहीं बोल रहे, हम तो बोल दे रहे. So then first वाला तो then who's introducing him? Dr. Nair, are you introducing Dr. Arun Sanyal?
Good evening. In fact, there was a guideline, no? The order happens to be, I am introducing Professor Duseja.
Yeah, the problem is Abhijit has not joined.
Okay, if you would like to take the lead, that's perfect with me. That's a pre-recorded.
No, you can do, because I have checked up everything. Dr. Arun Sanyal and Dr. Bajaj, there were no details available. So I checked up Dr. Jasmant Bajaj from the internet and got some of, I know what work he's done, but I just needed to know the place he's worked at. But I think I was just wondering, this Dr. Arun Sanyal is also in the same unit.
That's right.
He's he's professor of medicine of division of gastroenterology, hepatology,
and
nutrition in Virginia Commonwealth University, because they're both working together.
Same department. Yeah, that's right.
And then anyway, he's been the president of ASLD, and his interest obviously has been hepatic encephalopathy, portal hypertension, and non-NAFLD and NASH. So this much only if we introduce, because anyway he's not a speaker. They're going to run his pre-recorded lecture.
Right.
No, whatever it is, the introduction has to be very, very short. Very,
absolutely, 2 lines. Yeah,
that's what. So shall I do it, Dr. Deepika?
So you are going to do Arun Sanyal?
No, I would say you are the leader. You're going to lead. So,
you want me to do Arun Sanyal, Dr. Sanyal?
Yeah, Dr. Deepika, aap kar do, because you've got the.
Yeah, that is what. So I'll stick on to Professor Duseja.
We'll start for 2 minutes. I'll introduce all of you as the chairperson, and then I'll let you take over. And as I requested earlier, we will have the discussions in the end rather than after each talk.
Should we keep time also to remind people?
Yes, please. Let's stay on time.
So let me just, the moment they start speaking, we'll get the stopwatch on. Okay.
How will you stop the recorded lecture? Hi, good evening, everyone. Ajay here.
That we can't do. I hope they've kept themselves in time. Dr. Duseja, we can't see you.
Yeah, I'm just switching on my video. Yeah, just
live.
Hi.
Yes, hi, we can see you.
Hi.
Congratulations on being selected as Secretary General of INSL.
Thank you
so we have a president in this group also, and we have the Secretary, Treasurer, as well as the Secretary General. Everybody is here.
Hello, wonderful. I think we are live now. Hello.
He should give you a back countdown, Dr. Puri.
So
before you go live.
But it's past 7:30.
Yes, sir. Now we are live.
Okay. Hello, everybody. Welcome to Hall B for Inasl. May I introduce the chairpersons for the current session? The chairpersons are Dr. Sudhanshu Patwari, who is the Chief of Gastroenterology at Sterling Hospital, Ahmedabad. Dr. Deepika Kedia, who is the Consultant Gastroenterologist and Liver Specialist at AMRI and Dhaukuri and Mukundpur, Kolkata. Dr. Harikumar Nair, who's the Senior Consultant Hepatologist at Apollo Adlux Hospital, Kochi, Kerala, and Dr. Abhijit Chaudhary, who's the Director of Clinical Hepatology and Research at India Institute of Liver and Digestive Sciences. And may I request the chairpersons to take over and start the proceedings.
Good evening. The first speaker today is Dr. Arun Sanyal. He is a professor of medicine at the Division of Gastroenterology, Hepatology, and Nutrition at Virginia Commonwealth University, Richmond in US. Professor Sanyal is known to all of us because he's come to give talks to us regularly, and he's published prolifically. His interest has been hepatic encephalopathy, portal hypertension, and lately NAFLD and NASH. And his talk today is going to be, he's going to talk about GLP-1 receptor agonist in NFLD, current evidence of role in management of NFLD. Unfortunately, Dr. Sanyal could not be present, so we are going to be playing his pre-recorded lecture. Can we start the recording, please?
Mr. Chairman, ladies and gentlemen, it's a pleasure for me to talk to you today about the use of GLP-1 agonists for NASH. Here are my conflicts of interest. NASH is part of a multi-system disorder. At its root cause is diet-induced obesity, and even in lean individuals with NASH, such as those that you see in India, there is an increase in visceral adiposity and all of the biochemical markers that go with increasing adiposity. This in turn leads to metabolic stress, systemic inflammation, and fibrosis. The net consequence of this systemic metabo-inflammatory and fibrotic state is reflected in various end organ diseases, such as vascular in the form of hypertension, cerebrovascular disease, coronary artery disease, peripheral vascular disease, heart failure with preserved ejection fraction, type 2 diabetes, and chronic kidney disease, and NASH, of course, is the hepatic manifestation of this condition. We recognize many of these comorbidities as risk factors for fatty liver disease. Of course, these are all competing threats to life, and the leading outcomes in a patient who has one or more of these end organ diseases are cardiovascular, CKD, cancer, and liver disease. The second point I would like to make is that NASH is a victim of extrahepatic circumstances. When we do a liver transplant, we put in a liver that does not have any steatosis in it. But when you follow these over time, as we showed over 20 years ago, virtually all patients develop recurrent steatosis, and the development of steatohepatitis follows. So when you think about how to de-risk the threats to patients' life, we again come back to our basic paradigm of a systemic disorder that affects multiple end organs, of which the liver is one. So we know there are many treatments to treat vascular disease, heart failure, type 2 diabetes, chronic kidney disease, etc. But one treatment that really we need to think about if we're going to treat all of these competing threats to life is to get to the root cause. And the root cause, of course, is excess adiposity and systemic inflammation. From a hepatic perspective, what we have to think about is the core conceptual framework that is needed to establish the benefits of therapy for the liver disease. So if you think about the liver disease as it progresses from its beginning, as shown in this cartoon from the left, all the way to its progression to cirrhosis, the first step for a metabolically acting drug would be to reduce disease activity, which means it has to resolve steatohepatitis and improve activity scores. And eventually this should translate into improvement in fibrosis, which then should result in less cirrhosis. Less cirrhosis, of course, means less liver-related outcomes and death. So in the short term, depending on the mechanism of action. Our goal is to reduce activity and fibrosis. These are surrogate outcomes, and in the long term to reduce clinical outcomes. So in the context of fatty liver disease, you can think about stage 0 to 1 NASH, and then a critical stage, which we call at-risk NASH, defined by the presence of steatohepatitis, high activity scores, and stages 2 and 3, which are at higher risk of progressing to cirrhosis, and once you get to cirrhosis, an increased risk of progression to outcomes. So that is the normal population that we generally consider for treatment, because once you get to cirrhosis, you progressively lead to outcomes, and it's expected that we will have 2 to 3 million people with cirrhosis in the US by 2030, and this is expected to result in almost 37,000 patients living with end-stage liver disease by that time. Yet liver transplants, which are limited by the number of organs available, is only about 8,500 to 9,000 annually. So the goal, therefore, is to slow down or reverse the progression to cirrhosis, and drugs that act on disease activity should result in reduced progression to cirrhosis, because activity drives fibrosis progression. Okay, having set the stage now, let's talk about GLP-1s, and specifically about semaglutide, which has many ideal characteristics as a potentially effective therapy for NASH. Now, coming back to our principal paradigm of a multi-system disorder, let's think about a holistic approach and how we can actually improve all of the end organ diseases. And there is already evidence that weight loss and decreasing adiposity improves all of these different end organ diseases. Now, we've learned a lot about the neurocircuitry of appetite, and we know a number of pathways and hormones that can be modified or which can be leveraged for therapeutics. Of these, GLP-1 is a very important peptide, as shown in the table on the right. The cell source are the L cells in the intestine, and they target the GLP-1 receptors, and they reduce food intake. And there are now very beautiful data, and these are data from semaglutide published in the Lancet in 2018, showing a very beautiful dose-dependent decrease in body weight with increasing dosing of semaglutide from 0.05 to 0.4 milligrams daily, and with liraglutide as a comparator. So clearly semaglutide causes significant weight loss, and you notice that this weight loss is in the range of 10 to 15%. So this is almost bariatric level weight loss that you can get with semaglutide. Now here are other data, and these are 2.4 milligrams given once a week parenterally. And here we see different types of results. So in the step 1 study, you're seeing, across all these studies, baseline weights of 100 kilos or higher. And after 68 weeks, you're seeing sustained improvement, as shown in the orange bars with semaglutide, whereas placebo in the green bars don't show that much effect. And you can see that weight management with IBT and sustained weight management, all regardless of the setting, after 68 weeks, you get a sustained weight loss with semaglutide, thereby indicating that this is really a very viable drug, and this has now been approved for the management of obesity. Okay, so moving on then, look at our other effects of GLP-1. So GLP-1 has other effects, including cardioprotection, decreased coagulation, decreased postprandial lipids, improved glycemic control, reduction in liver fat, improvement in vascular biology, and actually increasing natriuresis and increasing diuresis. So from a NASH perspective, some of the potentially beneficial effects are increased glucose metabolism and hepatocyte survival, while decreasing inflammation, triglyceride storage, and free fatty acid storage. So all of these then should translate into improved other end organ diseases, as well as an improvement in NASH. There is already a plethora of literature, which is summarized in the next slide, showing that GLP-1 agonists, and these are a variety of different GLP-1 agonists as a class, improve all-cause mortality in people with type 2 diabetes, with high-risk features for mortality, hospitalization for heart failure, composite renal outcomes, and worsening of kidney function. So in a high-risk population with type 2 diabetes, it is look at the liver disease. So once again, coming back to a holistic approach, we know that GLP-1s have been established to improve many of the competing threats to life in this population. And of course, for vascular diseases, etc., there's a role for statins, smoking reduction, and then the role of SGLT2s, which are often given at the same time in these patients. So now looking specifically at the first study that was published was the liraglutide trial, where compared to placebo, liraglutide produced a decrease in activity scores, steatosis, ballooning, inflammation, and fibrosis stage. And on the left, you see that liraglutide also produced an improvement in MACE. So based on this, a phase 2b trial was developed, which is shown in the following slide. And what you see here is almost a 59% improvement in resolution of steatohepatitis compared to 17.2% in placebo in this trial. This was published in the New England Journal in 2020. However, when we looked at fibrosis, we did not see any significant improvement, which initially was a little disappointing. But then when you take a deeper dive, you look at the proportion of people who had improvement, no change, missing or worsening fibrosis. What you see over here is that there is a progressive improvement in fibrosis. Now, why do I say that? If you focus on the pink wedge in the slide and look at the placebo data on the right, that's 18.8% of patients who had worsening fibrosis. Now, if you go all the way to the left and you go from 0.1 to 0.2 to 0.4 milligrams, what you see is that the proportion of people with worsening drops stepwise from 10 to 7.7% to 4.9%. And so if you have a drug that works primarily by reducing activity, the first thing that will happen is that your fibrosis progression will slow down. Then you'll see a period of stabilization, and then you will see resolution. So this gives us hope that in longer term studies, this will translate into less progression to cirrhosis. Also remember, progression to cirrhosis is primarily a function of decreased progression of fibrosis rather than resolution of fibrosis. Now, when you look at other frontline therapeutics and look at their lipid profile, their impact on MACE, stabilization of GFR, glycemic control, and their ability to reduce NASH progression, they're all somewhat suboptimal at this point in time. So when you put it all together and look at GLP-1s, we know it causes weight loss. We know it is neutral with respect to atherogenic profile, but we know it reduces MACE. It improves GFR. It improves glycemic control. Now what we really need to show in the phase 3 trial, which is currently ongoing, is whether it will actually prevent progression to cirrhosis. So the way I think of NASH management paradigms in the next decade is that after the initial diagnosis, we have to assess the end organ status of all the organs. You start with weight loss regimen and then use drugs only as second line. Use statins as indicated and fibrates if increased triglyceride is present. And then your first approach would be, particularly if you have type 2 diabetes, is to start with GLP-1 agonists with or without an SGLT2 inhibitor. Now, we reassess the patient after a period of time. And then if there's residual disease and you have ongoing fibrosis, you may consider additional add-on therapies. Why do I say this? This is because holistically speaking, the GLP-1s and the SGLT2s already have multiple benefits on various end organs in this population. And if you can use one drug to treat multiple end organs, that's always better than using multiple drugs to treat a single end organ. And eventually, of course, we need data. And we need the data to show that in our NASH population, when you use it specifically with the idea of treating NASH, you improve mortality, healthcare cost, function, and quality of life. So the goals of the Essence trial, which is the phase 3 trial that is currently ongoing, is to increase resolution of NASH and improvement in fibrosis in the short term, and in the long term to reduce progression to cirrhosis and have improved outcomes. I thank you for your attention.
Let's move on to the next session. This is on the role of combination therapy in NAFLD. The current evidence, as well as we all know that there is a rich pharma pipeline when it comes to NAFLD therapy. So the next lecture would explore the possibility of current evidence on combination as well as future prospects in combining. This lecture is delivered by none other than Professor Ajay Tuseja. He's a professor of, doesn't need any introduction to liver audience in this country. He's professor of hepatology at the prestigious PGI Chandigarh. Over to you, sir, Professor Tuseja, to deliver the lecture.
Thank you, Dr. Hari Kumar, for those kind words. And can I request the organizers to correct the time clock, on the timer? Well, this was probably on the discussion. So let me have my 12, 13 minutes, whatever. So at the outset, my sincere thanks to Dr. Kaushal Madan, Dr. Rao, and Inasl for giving me this opportunity to be part and parcel of this, the annual meeting of Inasl. So the job I have been assigned is to talk or give you the evidence about the combination therapies in NAFLD. We understand that fatty liver disease is a difficult disease to handle because there's a complex pathophysiology which is involved, in causing NAFLD, NASH, with or without fibrosis. So people are, tackling on various targets while, using pharmacotherapy in patients with NASH. I'll not go into the indications of pharmacotherapy here, but then when we talk about pharmacotherapy, I think there are three major, kind of drugs which are used. One are what we call the drugs which act on the metabolic pathways, say called the insulin sensitizers and the long list of those drugs. Then you can have what we call the anti-inflammatory drugs, and then you can have what we call the anti-fibrotic drugs. So there's a long list, and I think for the sake of residents, I think this probably would be the only clinical indication today which probably would have around 100 clinical trials going on with multiple drugs, targeting, individual targets and fatty liver disease. But then the results so far tell us that the monotherapy in fatty liver disease has really not been very, very encouraging. And if you look at the results, and you just heard Dr. Sanyal saying that most of the clinical trials would actually look at either the resolution of NASH or the improvement of fibrosis by one stage. And you look at, the drugs which are, the current drugs, what we call them as pioglitazone, vitamin E, or the newer drugs, say obeticholic acid, even for that matter, GLP-1 agonist, elafibranor, or resmetirom, anything. I think the difference between the placebo and the drug in causing the resolution of NASH is not too wide, maybe 20-30% difference. And the lesser is the difference, say, for the improvement in fibrosis. So when we talk about the rationale of combining therapies for NASH, so one reason is that, yes, single drugs, as I said, they have limited efficacy. Whether you look for the resolution of NASH or you're looking for improvement in fibrosis, as I said, I think there is a limited efficacy. So we are trying to look at, we want to improve the efficacy. Now, whether that will really happen or not, I think I'll show you some data on that. But then the aim is to improve the efficacy, and not only the liver-related, efficacy. You just heard Professor Sanyal saying that the multi-system disease, which fatty liver disease is, you're not looking at the liver benefits, you're also looking at the extrahepatic benefits. And we talk about extrahepatic benefits, it means that the improvement in cardiovascular mortality, your improvement in diabetes, your lipid control, your weight reduction. So everything, I think, need to be taken. So you're looking for those kind of combinations where, in addition to the hepatic benefit, you could also have, extrahepatic benefit. The second is, all these drugs we know are associated with side effects. There's the issue with tolerability of these drugs. So again, and this could be related to the kind of dosage which are used in these drugs. So by combining the drugs, what you're trying to do is that probably if you're able to reduce the dosage of these drugs, to make these drugs, more tolerable and reduce their side effects. So that would be, the second aim of using the combinations. We also know till date, except, the drug saroglitazar, which has been approved by DCGI in India, there are no other drugs which are approved by any regulatory agency, may it be FDA or EMA. But the current drugs which are usually recommended by most of the societies we know are the pioglitazone, vitamin E, and as I said, saroglitazar. And the other drug which looks in the pipeline is obeticholic acid. So since these drugs are not been recommended, as I said, so what we have today about the combination treatment are the strategies. Strategies to improve the efficacy, strategies to reduce the side effects. As I said, not even the single drug is approved. So obviously the combination is also still not approved. So we're just, kind of working on these combinations to see, how can we improve the efficacy and how can we reduce the drugs. Then we also know that there's a long list of, the emerging pharmacotherapy in fatty liver disease, and some of the drugs actually have failed in phase 3. For example, the selonsertib molecule, which is the ASK1 inhibitor. Some are in the pipeline, like sinicriviroc, which is, a chemokine inhibitor, the anti-inflammatory drug, and there's so many in phase 2. You heard about the semaglutide from Professor Sanyal, the GLP-1 agonist, the SGLT2 inhibitors. You have the second generation FXR agonist beyond, obeticholic acid like cilofexor, topifexor, and then you have, the ACC inhibitors. So what people are now doing these strategies is that how can you combine these drugs? And I'll, as I said, next 10 minutes will show you some data on this to improve the efficacy. That is one aim, and to reduce the side effects and the tolerability, to improve the tolerability, that is the second aim. Now, let me start with the kind of drugs what we have or which are approved by, few of the societies. Say pioglitazone would be approved by almost all the societies across the globe. And this is actually based on not only this PIVENS trial and thereafter so many other studies and the meta-analysis where it has been shown that it is effective both in diabetic and non-diabetic patients with NASH. But then if you look at this PIVENS trial and look at the side effects of the drug, in comparison to, placebo, I think the gain in body weight, BMI, and the body fat was much, much more with, pioglitazone in comparison to the placebo. And we know this is related to, the fat proliferation, the fluid retention, and the decrease in, glycosuria, increasing appetite. So multiple, mechanisms involved there. And there's some cardiovascular issues also which are, associated with pioglitazone. So what is the kind of strategy to reduce these side effects? So this is a combo of, the pioglitazone with SGLT2 inhibitor, right? So we know the SGLT2 inhibitors, are the newer class of anti-diabetic drugs. If you were there in Hall A, I think the very nice lecture by Dr. Puri, where he covered all the anti-diabetic drugs to be used in cirrhotics. So SGLT2 inhibitors, we know they cause glucosuria, they cause weight loss, right? So all the side effects of, glitazones, which happen, say, for example, with pioglitazone. So this combination is the pioglitazone with empagliflozin. Empagliflozin is again an SGLT2 inhibitor, but this is just a strategy. The trial probably has stopped recruiting, but we need to, wait for the results. The talk of the town these days, is the obeticholic acid, right? And it has been shown both in per protocol analysis and also, in the ITT analysis that it does improve hepatic fibrosis. The later the analysis actually had also shown that it improves even the inflammation. But the problem with this drug, one is the pruritus, which is a class effect of all these FXR agonists. And second is, is the dyslipidemia. The LDL and the total cholesterol, goes up, because this is a bile acid synthesis inhibitor. And once, and that the bile acids are formed from the cholesterol. So, you are stopping the synthesis of bile acids, so the cholesterol would go up. So this is one study which was published 2 years back, and so-called the control trial. Very simple, again, a strategy. We are trying to limit the side effect, the dyslipidemia, the side effect of, obeticholic acid, and they simply just use the atorvastatin in combination with obeticholic acid. And Initial 4 weeks, it was all obeticholic acid. After 4 weeks, they had, added the atorvastatin. But at 4 weeks, when they look at the LDL cholesterol and the LDL particle, obviously the concentration was high. But at 8 weeks after using in combo with atorvastatin, I think they were controlled. So I think this is what is said about OCA, is that yes, dyslipidemia is an issue, but yes, by using the statins, probably you're able to control it. So this is kind of reducing the side effect. That's the kind of strategy here. Then, as I said, there are a lot of strategies which people are using in combination to improve the efficacy. And as you heard Dr. Sanyal, the target population in patients with NASH where you will use pharmacotherapy would be the patients with F2 or F3 disease. You would not like them to get into cirrhosis. So again, these are two ongoing studies. The tandem trial is a combination of the drug called tropifexor, which is again a FXR agonist, and sinicriviroc, which is your chemokine inhibitor. And this is right now recruiting. This is a phase 2 study, and the other study is from the company Novartis, which is an ongoing phase 2 study, and it's a global study. In India also there are, I think, 14-15 centers. We are also part of this study called the Elevate study, which is combining the tropifexor, which is again an FXR agonist, with licogliflozin, which is an SGLT2 inhibitor. So what are they doing in the tandem trial is, and this is the study design of the tandem trial, the tropifexor and the sinicriviroc used in this. But then look at this. What they're trying to do here is they're trying to reduce the dosage of tropifexor from 140 microgram and 90 microgram. So the idea is that we know that FXR agonists, the class effects, the pruritus and the dyslipidemia, which I just said is one of the issues with the FXR agonist. So here, the primary objective of the study is not to look at the efficacy. They're looking at the safety and the tolerability of the combination. And they're trying to reduce, the lower dosage of, tropifexor. So that is the strategy here, that by reducing the lower dose of tropifexor, can you avoid or reduce the side effects, especially the pruritus and dyslipidemia? And this is the Elevate trial, which I said from Novartis, which is using the tropifexor and the licogliflozin. Licogliflozin, again, is an SGLT2 inhibitor. Tropifexor is an FXR agonist, and here you're trying to improve the efficacy of the, improving the F2 and the F3. As I said, this is an ongoing phase 2 trial, which is good. One class of drugs, this is from the Gilead. This was a molecule called, GS976, and now this has been renamed as the Forsokostat. This is a molecule which is an ACC inhibitor. Again, for the sake of, resident, what is ACC or acetyl-CoA carboxylase? These are, two kinds of ACC enzymes, ACC1 and ACC2. ACC1 is predominantly in the cytosol, and ACC2 is predominantly in the mitochondria. So ACC enzyme is actually involved in converting from acetyl-CoA to melanin-CoA, and melanin-CoA is then involved in, in de novo lipogenesis, and this also reduces the fatty acid oxidation. So if you inhibit this enzyme, your de novo lipogenesis will go down, your fatty acid oxidation will go up, so you will have less of steatosis. But while you're doing this, and the ACC inhibitor is doing this, there is reduction in the polyunsaturated fatty acids which happen, which somehow upregulate the genes which are involved in lipid synthesis, like the SREPP and the GPAT, and ultimately you may have hypertriglyceridemia and increased VLDL secretion as a side effect of Forsokostat. Again, a very simple strategy. This was again, presented as a late breaking in 2019 ASLD. I don't think this has been published as a full paper, but then in Forsokostat, they added just fenofibrate, to reduce the hypertriglyceridemia. And this combination, they found that not only improved the, hepatic fat and the liver biochemistry and the markers of fibrosis, was also reduced the hypertriglyceridemia, which is, was an issue with the Forsokostat. Then I think last 1 or 2 minutes, I'll just take, people are now using combination of more than 2 drugs. So a mix of 3 drugs in various combinations. And one of this drug is using a combination of cilofexor, which is again an FXR agonist, with semaglutide, which you just heard is a GLP-1 agonist, and Forsokostat, which I told you is an ACC inhibitor. And this is again in NASH F2 and F3. But in fatty liver disease, yes, you need to prevent patients to get into F4 or cirrhosis. But once they have already cirrhotic and they are already F4, I think obviously the reversal of fibrosis or regression of fibrosis becomes even more difficult, and we really don't have good drugs but for some retrospective analysis of using vitamin E and metformin in cirrhotics. So this is a drug which, a trial which was published last year, and I'll show you data on this, called the Atlas trial, which was used in F3 and F4 fibrosis. And they used 3 drugs. One is cilofexor, for Socostat, which I said is the ACC inhibitor, and selonsertib is the ASK1 inhibitor, which, Gilead had 2 big trials of Stellar 3 and 4. Ultimately, selonsertib had failed, but in this trial, they were using this combination. So as I said, this is the trial which is using the cilofexor, semaglutide, and the Socostat. But the trial which I want to show you data is this, which was published last year, called the Atlas trial. And they had 3 drugs. One is the selonsertib, which I said is the ASK1 inhibitor, 18 milligram. Cilofexor, cilofexor, the normal dosage uses is around 120 milligram. So here, when they were using in combination, they could reduce the dosage to 30 milligram, thereby trying to reduce, again, the side effects of FXR agonist. And the third drug was the Socostat, which is, as I said, is the ACC inhibitor. So the trial went on for 48 weeks, almost a year. And as I said, 56% of these patients were cirrhotics, or if they had bridging fibrosis, which means F3, and around 60% were F4 or cirrhotics. And they were trying to look for, improvement in fibrosis without worsening, and also some other, endpoints. Let me just quickly show you data. Though they did not have, much improvement in NASH, but then if you look at 1-stage improvement in fibrosis, though it was not statistically significant, but then the combination of cilofexor and Socostat had 21% of them had 1-stage improvement in hepatic fibrosis, in contrast to 11% So, 1-stage improvement even happening in 20% of cirrhotics, I think is probably worth it. But as I said, they didn't reach the statistical significance. But if you look at the improvement in the NAS score, I think this was statistically significant, 36% in the Socostat and the cilofexor group, in comparison to 11% in the placebo group. And if you look at the individual components, made the steatosis, lobular inflammation, and ballooning, this was much more commonly seen in the Socostat, which is ACC inhibitor, and the cilofexor, which is an FXR agonist. Another important, message from this study, as I said, they used a lower dosage of cilofexor, which was 30 milligram. And when they looked at, the incidence of pruritus, which we know in the Regenerate trial was close to 50% with obeticholic acid. Here, by reducing the dosage of cilofexor, the pruritus happened at only around 20-25% in comparison to around 80-90% in the placebo group. So, and there was no, dropout because of the pruritus. So I think, again, as I said, you could reduce the dosage, you're trying to improve the efficacy, and you can reduce the side effects. So I think, ladies and gentlemen, let me summarize what I said in the last few minutes is that NAFLD and NASH, we know, has a complex pathophysiology. There are multiple targets which are being, used as, treatment. And there are multiple drugs, as I said, close to 100 clinical trials going on, individual drugs, which are, targeting different, mechanisms. But the problem is about the efficacy, number one, and second is about the safety and the side effects. And that is the rationale of using the combination of the drugs, that you want to improve the efficacy and you want to improve the tolerability or reduce the side effects. Now, there are dual kind of combinations, which I said, which are ongoing. There are triple kind of combinations which are, going ongoing, and the combinations are happening with the kind of current drugs we have, say pioglitazone or saro, or say for that matter obeticholic acid, and the future drugs which I said. And except for the Atlas trial, which had shown some promise, other, the efficacy results of other trials obviously are awaited, and we are trying to, look at the improving the side effects. Overall, I think I feel that yes, NASH, when you're looking at pharmacotherapy, is a difficult nut to crack. But yes, we are trying to, get ready for this combination therapy, and I think the future will decide the role of, this combination therapy in NASH. So thank you very much for your kind attention. I'll stop sharing my screen here. Thank you. You need to unmute yourself, Dr. Deepika.
Thank you, Dr. Duseja. The next speaker is Dr. Jasmohan Bajaj. His topic today is gut-liver axis and pathogenesis of NFLD. He's not present. We are going to be playing his lecture. He's a professor of medicine at the Division of Gastroenterology and Hepatology and Nutrition at Virginia Commonwealth University, Richmond, US. His interest has been cirrhosis, hepatic encephalopathy, and now microbiota in liver diseases. Over to his lecture.
In emerging therapies in NASH. This is the outline. Gut-liver axis changes. Studies in changes in NAFL before and after the development of cirrhosis are important for us to study. Longitudinal changes, what happens when we do things to patients with NASH or what happens over time in these patients. And last but not the least is modulation with therapies such as probiotics, prebiotics, diet, fecal microbiota transplant, and FGF19 agonists. So this is the very complicated gut-liver axis that gets even more complicated as patients go further in their disease process. In the lumen up top in the yellow is the microbiome. It can be affected by things such as rifaximin, probiotics, fecal microbiota transplant, etc. Then you have the epithelial barrier in the pink that can have paracellular and transcellular changes. Then you have the gut vascular barrier with the enteric nervous system, sympathetic nervous system, which has a lot of epithelial cells as well, which has a lot of lymphocytic cells, mononuclear cells, adipocytes, as well as other cells that interact with the bacteria and the bacterial products that come through the gut barrier. And then this goes through the portal vein, the portal venous circulation. This finally then goes to the liver, as well as affects the bile ducts, as well as the intrahepatic target cells such as the HSC, Kupffer cells, and platelets in the endothelium. So these can cause a huge change, and multiple microbial products such as bile acids, trimethylamine, acetylamine, fatty acids, flagellin, LPS, bacterial DNA, they all can have a unique impact on patients, as well as the gut-liver axis that changes in each stage of disease as the disease progresses. So before we go any further, we have to remember the microbiota is not a static thing. The structure and function of the microbiota depends on many, many things. Active alcohol use, antibiotics, comorbid conditions, medicines, diet, which is very important, organ failures, host genetics, liver disease stage, as well as etiology. So all of these things take a huge influence on the microbiota structure and function. Therefore, we need to figure out what specifically is unique to our population that we're looking at, and not just assume that everything that is published will be automatically applicable for the population that you take care of. So let's first talk about pre-cirrhotic stages of NAFLD, which we know is a huge problem in the community. You have obesity, you have diabetes, you have metabolic syndrome, and many of these conditions overlap in patients with non-alcoholic fatty liver disease. In the first part is the stool microbial studies of families, and you can see there's on the top, there's a difference in the Pasteurellacea, Lactobacillacea, Lactospiraceae, which are higher in the good bacteria, which is Lactospiraceae and Ruminococcacea. Lactospiraceae are higher in the controls, whereas the other bacteria such as Ruminococcacea, Porphyromonaceae, and Veonelaceae are higher in NAFLD. These can be associated with negative outcomes in certain other conditions. In this bottom right, you can see Enterobacteriaceae and specifically the species, the species Escherichia. You have normal patients, which means neither obese nor NASH. You have obese patients without NASH, and you have the NASH patients. And you can see Enterobacteriaceae, which is the family that contains E. coli, Klebsiella, etc., has the highest relative abundance in NASH patients. And when we look at the Escherichia specifically, that's the E. coli, the Enterobacteriaceae, was largely because of Escherichia. The same for the Bacteroidetes total bacterial ratio. This is supposed to be a relatively benign bacteria. So the proportion of that should actually be high for this to be a relatively benign microbiome. So healthy controls, simple steatosis, and NASH, that's what happens. As NASH progresses, the simple steatosis progresses to NASH, the relative proportion of the bacteria taken over by Bacteroidetes phylum goes down. What happens when patients actually advance with their cirrhosis or through the fibrosis chain? In this study done in the US, you have patients with NASH with and without fibrosis F2 or more than F2. And you can see the rate of patients Bacteroidetes and ruminococcus is high in these patients. So look at the metabolic syndrome here in the red, in the bottom left side. Follow the red bar. And you can see with the metabolic syndrome, the red bar increases. And this red bar again goes down, goes higher as stuff progresses from F0 to F1 to F2. So it is important for us to realize as disease progresses from pre-cirrhotic to F1 to F2, the gut microbiota changes hand in hand with that. It is still not clear whether this is the cause or the effect, because obviously in humans, NASH takes decades to years to develop. What happens after cirrhosis develops? In this side is a study done by our group, is NASH cirrhosis versus non-NASH cirrhosis. And on the right side is alcohol-related cirrhosis versus non-alcoholic cirrhosis. And you can see there are differences between the groups. The Bacteroides, Porphyromonas, and Veillonacea are different here, whereas the other group of bacteria, Ruminococcus, Lactospiraceae, and Enterobacteriaceae, are higher in patients with alcohol rather than non-alcoholic liver disease, cirrhosis. So what it tells us that even after the development of cirrhosis, NASH may have a different signature of the microbiota than alcohol-related cirrhosis, at least in our population. Another little twist in this is the endogenous production of bacteria, because we assume that most bacteria hurt the body by producing all those products that we talked about, such as LPS, flagellin, bacterial DNA, that sensitize the gut-liver axis. But in very rare conditions, bacteria such as Klebsiella pneumoniae can also endogenously produce alcohol. And this is in children. It was first done in a mouse model, and then in children, which obviously don't have access to exogenous alcohol. Normal, obese, and NASH children, the endogenous production of alcohol is highest in the children who had NASH. And this was also then confirmed in very rare situation of autobrewery syndrome, in which this can result in production of Klebsiella pneumoniae that produces alcohol, and that can result in NAFLD in patients with cirrhosis. This was confirmed in a twin study in Korea as well. So it is an intriguing concept, but this again tells us that there are many ways in which the microbiota can actually worsen the NAFLD process, in addition to all the other insults that are happening, including diabetes and obesity and metabolic syndrome. What about the presence of NAFLD in cirrhosis? So in patients with liver disease, since this is very difficult to do liver biopsies in people, in this nice study, they did a gut microbiota derived signature to come up with a potential for a non-invasive stool test for diagnosis of fibrosis with an AUC of 0.936. Another study did the blood microbiota, which is even better or easier to get than the stool microbiota. And you can see this is the number of copies in serum and the diversity. So the diversity is low in patients with NAFLD and fibrosis, but the copies in serum is high, which tells you that fewer bugs, but larger number of those bugs are present in the serum, or quote unquote leaking into the serum. But these are very nice proof of concepts. We need multi-center studies in large numbers to increase the uptake of this methodology. What about the signature of the bacterial products? We talked about very briefly with a very rare product, which is alcohol. But what about bile acids? As we know, bile acids are actually produced by the liver. They're conjugated. Then when they're secreted in the sputum, they're either deconjugated first, and they can also be, after that, they can form secondary bile acids. In addition, there's oxobile acids, isobile acids, as well as sulfation or desulfation of the bile acids. So the gut microbiota have a huge imprint on the bile acids that are present in the circulation, as well as in the stool. In this study that was done, the fecal bile acids in NAFLD compared to controls, there was higher total bile acids, higher primary bile acids, and lower secondary bile acids. What it tells you is there is lower formation of secondary bile acids. But this may just be because of progression of cirrhosis, because as cirrhosis progresses, regardless of NAFLD, there is a reduction in secondary bile acids and increase in the primary bile acid ratio. So this may potentially be just a reflection of disease progression as far as cirrhosis and concerned rather than specifically something unique for NASH. We talked about cross-sectional studies in NAFLD and microbiota, but what about longitudinal changes? There can be potential changes in the microbiota as disease progresses or over time. In this study done by Dr. Wong, there was a correlation between the changes intrahepatic triglyceride content and fecal bacterial abundance over 6 months. So when NASH resolved, there was lower intrahepatic triglycerides, which was associated with higher bacteroidetes and lower firmicutes. You remember bacteroidetes was things that we really do want in our population with NAFLD. So again, this does not answer the question, what came first, but it clearly says that they are linked. As the lower the intrahepatic triglycerides go down, the changes in the microbiota go up. What about in inducing NASH? What about causing NASH? By some people who were basically put into a situation where choline deficiency was induced by giving them a diet. So these patients were kept in a clinical research center and all the food was actually given to them by the researchers. So it was a very intensive study. And what they found, gamma protobacteria, which includes E. coli and Enterobacteriaceae, were associated with choline deficiency induced fatty liver. So it tells you that as patients develop fatty liver due to choline deficiency, there is an increase in gamma protobacteria, which include E. coli, as well as erysipelas fructi. This tells us that microbiota change can rapidly predict who develops fatty liver disease or not. So things are getting a little more cohesive now about the role of fatty liver and microbiota. So can we actually change this into therapies for NAFLD that can be done for a long time? So as you know, the natural history for non-alcoholic fatty liver disease is many years and decades. So you want to have a therapy or therapies that can be taken by the patient for a very long time or could have a very large impact quickly. So we come back to the same thing. You know, you have the fatty liver, majority of patients are stable. Some of them develop NASH. Some of them have stable or regression of fibrosis, but some of them progress to cirrhosis. And then, of course, with cirrhosis, they have liver failure and hepatoma and death. Current studies for microbiota are like this, little blips in the natural history. What you need is sustained studies with multiple interventions for that to actually act in this patient population. Because as you know, NAFLD is just one part of the entire metabolic syndrome, and we need to actually make this something together. So what are the studies that are happening? Right here, prebiotics, probiotics, symbiotics, FMT, obeticholic acid, and antifermin. And we are going to talk, this is something we've already talked about, but this is a summary of the treatments that target the microbiome. Currently, the sum total of the evidence is not very convincing the way things stand. And so what we need is potentially personalized nutrition with gut microbiome changes. You want to target the dysbiosis, target the metabolism, not just which microbiota are there, but what the microbiota are doing, improve the gut microbiota integrity, and that's how you move forward. We need to then go beyond associations and find out which bug or which groups of bugs are actually doing this. So in summary, NASH is a multifaceted disorder which is associated with an altered gut-liver axis. Bile acid perturbations and microbial composition changes worsen over the course of fibrosis severity with more extreme changes towards cirrhosis. Treatments for NASH are increasingly focused on the gut-liver axis and modulation of bile acids. At this time, there is inconclusive evidence that using pre-pro-symbiotics or other studies can improve NASH from a regulatory standpoint, although there's enough proof of concept. FMT studies in NASH are undergoing, but again, are also not conclusive. Gut microbiota changes in NASH will likely be part and parcel of an overall strategy to treat metabolic syndrome. And this is my acknowledgement, and I thank you all for your time.
Let us go to the next session by Dr. S.P. Singh. Dr. S.P. Singh is a senior professor of gastroenterology at Cuttack Medical College. He was formerly a president of INSL also, and I think he is working on NAFLD and NASH for last more than 20 years. And his topic of discussion is the call for change in nomenclature of NAFLD relevant or not? Professor S.P. Singh, please.
Yeah, I am unable to share my video. Please. Yeah.
Dr. Singh, share screen. You're not managing.
Yeah, so I think there's some problem. I'm not being allowed to.
Akash, please help.
Is my video on now?
They're already allowed.
Your video is not on, sir.
No, I have switched it on, but it is not getting on. Anyway, do I continue to speak without?
Is your video not coming on?
So what I'll do is, if my video is not coming on, I should not waste time. And am I audible?
Yes, sir.
You are
Yes, sir.
audible. Yeah.
Can I share my slides then?
Yes.
Yes, sure.
Yeah, at the outset itself, I said it was, my video was switched off. So I
Now
said,
we can see you. Dr. Singh, we can see you.
Okay, thank you. Thank you.
We can see you, but not the video.
Yes.
Yeah.
Now we can see
Your
you.
slides are seen.
Okay. Good evening to all of you, all those from South Asia. Good afternoon to people in Europe and good morning to people across the Atlantic. I have been asked to speak on is the call for change in nomenclature of NAFL relevant. Here are my disclosures. Committed to evidence-based science, aversion to eminence-based whataboutery, chairman Inasl task force on NAFL, not MAFL. And I've authored multiple NAFL versus MAFL rants. I use the word rant because some of the editors have rejected my letters by saying they are rants. There has been a tremendous clamor for a change in the name. Is it justified? What's in a name? That which we call a rose by any other name would smell as sweet. That's what this is from Romeo and Juliet by William Shakespeare. But the problem with NAFL name change is much different. It is not just merely a change in name. It's a question of concept disease, concept about the disease, about the entity itself. It is not as simple as just a name change. And all of this began by an article published last year, which was supposed to be a consensus article, where they proposed this name change and they attributed the name to Ludwig, which was not true. Ludwig is not the person. He coined the term NASH. Fatty liver disease without intake of alcohol has been known for a pretty long time, almost 3/4 of a century. Initially, people call it fatty infiltration, hepatic steatosis, and so on and so forth. Ultimately, it was Klatskin in 1979 who coined the term non-alcoholic liver disease, and probably Schaffner and Thaler in 1986 coined the term NAFL, exact word NAFL. It has taken the hepatologists, people working on NAFL, almost, half a century to convince people the importance that it's not, merely some imagination of the radiologist, but a real entity which needs to be addressed. It has taken almost half a century. And I am proud to say that India has become the first country in the world to identify the need for action for NAFL, not MAFL. And this picture shows our Union Minister Harshvardhan, who is launching the operational guidelines for integration of NAFL with National Program for Prevention of non-communicable disorders like cancer, diabetes, and so on. So it's very important. It has taken us a long time to convince people of the importance of what is NAFL and what we need to do about NAFL. And here comes the bomb. published in Gastroenterology 2020, a consensus-driven proposal led by a large list of people led by Muhammad Islam, Arun Sanyal, and Jacob George. Though Dr. Sanyal's photograph was there in this article, I doubt he was really genuinely, he was involved in this whole process, because I'm not sure, because no sooner that they came out with this, they coined this word MAFL, or this acronym MAFL. To begin with, I would say that they, people who play badminton know what's foot fault. So they began with a wrong. You can't have metabolic associated, because metabolic means either metabolism or dysmetabolism associated. You can't have, association twice in the name. Okay, and why did they do this? To emphasize the underlying condition of systemic metabolic dysfunction and need for a greater homogeneity. That's what they claim. And the other objections to NAFL was that it is a disease of exclusion. It's vastly heterogeneous entity. NAFL patients do consume alcohol, and the impact of alcohol, albeit in non-thin amounts, is under scrutiny. It's not clearly known, and non-trivializes why the word alcoholic demeans patients. And in the proposed diagnosis, mind you, they have put, metabolic dysregulation. They have done away with the term metabolic syndrome, because it was difficult to satisfy most patients. So they watered down metabolic from metabolic syndrome to metabolic dysregulation. Maybe later on they may say only not two factors, only one factor. And see, within months, a large group defected. A large proponent from the group which was speaking that the name should be changed. Genosi, Rinella, Sanyal, Harrison, Brandt, Goodman, Rohit Lumba, and Cohen, people who have been working all their lives on NAFL, decided to get away from it, and mind you, it's within months, and they said that it is a premature change in terminology. So how was that a consensus? And rightly so. Immediately, Ajay Duseja and Sunil Taneja from PGI Chandigarh wrote in a letter to the editor to JCEH, our own journal, that changing nomenclature to MAFL was not only premature but also confusing. And we then wrote a letter to the Journal of Hepatology protesting about this, because South Asia harbors 1/5 of the world's population and is, the epicenter of NAFL, global NAFL. And our voice has to be heard. And this letter was led by hepatologists from South Asia with a few from around the globe. And what we said that NAFL, not time for an obituary just yet. NAFL is not just a name, but a concept. And here the problem is again of East versus West. The Western hepatologists, conceptually, they put all the eggs in one basket. That's where they have gone wrong. When we looked at a patient in resource constrained Orissa, what we found that almost half of our patients did not have elevated insulin resistant values. The HOMAs were less than 2. That was shocking to us. And when we tried to publish this data, there was a lot of about it. The people were not willing to accept that this could happen. And then they said that this could be early NAFL, and later on these people would develop higher values of HOMA, right? But anyhow, we persisted and got this published. But then we were thinking that, is this peculiar to my region only? We published in this paper, what we found was we compared people without insulin resistance and with people resistant, almost equal numbers. And surprisingly, transaminitis was greater, was more in patients without insulin resistance, but fibrosis scores were similar. Within 3 to 4 years of our publication, we had this paper from Bangladesh, which said that 2/3 of the patients did not have they did not have insulin resistance measured by HOMA. So this region, that is the South Asia, our NAFL patients are different. NAFL, this is a complex problem, and a single hypothesis cannot explain the pathogenesis. Individuals with normal BMI also develop NAFLD, and in murine models, even with elevated hepatic triacylglycerol and diacylglycerol content, insulin resistance is observed. There is much more to NAFLD than mere insulin resistance alone. We have seen dissociation between fatty liver and insulin resistance in humans carrying a variant of the palatin like phospholipid 3 gene. NAFLD is associated with dysbiosis, is independent of the body mass index and insulin resistance. And in non-diabetic population, where you have increased serum total bile acid is independent of metabolic syndrome again. And the same thing is seen in soft drink consumption associated NASH also. This cartoon shows you the different so many pathways. How could you have a simple postulation, that only this metabolism is responsible for everything? It's not possible. I've already mentioned about, that in subject with PNPLA3 polymorphism, steatosis occurs independent of insulin resistance. And in NAFLD associated with environmental stressors like soft drink consumption, smoking, again, we have fatty liver independent of obesity, diabetes, and hyperlipidemia, and also metabolic syndrome. Same thing, by increased serum bile acid levels too seem to be independently associated with NASH in non-diabetics. Same with gut microbiota or dysbiosis associated with NAFLD. And last, we have, it has been shown that the circadian rhythm is also very important in NAFLD, and it has been shown that NAFLD is associated with the hepatic clot dysfunction and alterations in circadian gene expression, including those involved, especially in the inflammatory pathways. Just here we are. NAFLD is another story of the elephant and 6 blind men, each thinking that he knows everything. He is the know-all. When people say that a disease should not be by exclusion, non-Hodgkin's lymphoma diagnosis has almost been there for a century. No one has any problem with that. Then the question of alcohol, the impact of non-significant amount of alcohol and hepatic steatosis in NASH is unclear. Come on, it's silly. It's well known that alcohol intake in small amounts also leads to significant fibrosis and development of HCC in patients with NAFLD. Then why should both conditions more or less related to alcohol be brought under the umbrella of MAFLD? And then you put people taking alcohol under MAFLD and say that MAFLD patients have more bad liver damage and other problems, and so this is the real disorder we need to address. Besides the cultural issues, the word non-alcoholic goes a long way in destigmatizing the patient, especially in South Asia. Once you get the label of non-alcoholic, these patients are not bombarded. How much you drink? Don't say you don't drink. Patients are happier with this NAFLD label with it. Besides, it has taken, as I told you earlier, almost half a century to convince people about its importance. And now everyone is taking it seriously. Cardiologists, diabetologists, primary care givers, in addition to hepatologists, and a change in name will create unnecessary clinical confusion and coding issues. And then these people have used, ELPA, the European Liver Patient Association, and they have supposed to express their displeasure with NAFLD because they said that this, sort of stigmatizes them and, trivializes the problem. We wrote repeatedly to ELPA 3-4 times, but there has been no response from ELPA yet. What do our patients say? The smaller study, we have gone on to do a study in all South Asian countries. 87, almost 90% people are happy. They feel that they would prefer the term NAFLD to MAFLD. And then 80% feel that this does not trivialize them. This is the story of South Asia. Summarizing it, metabolic syndrome is only a part, although a major part of NAFLD. There's much more to NAFLD than meets the eye. The word metabolic in MAFLD would be an abject rejection of much of the scientific evidence we have gathered, and change of nomenclature will not address the issue. It could paradoxically misdirect therapeutics in the direction of metabolic syndrome. So while speakers haggled, won't audience get baffled in this debate between NAFLD and MAFLD? The moot question is, what do the proponents of MAFLD intend to do with those subjects who have fatty liver and don't have features of metabolic syndrome? With homogenizing a disease, you make it look homogeneous. It is, you yourself say it's a heterogeneous problem. And how can a name make it homogeneous? Besides, have the cultural issues across ethnicities and populations, the stigma of alcohol, been taken into account? No, they haven't. Let science prevail. This is not a bout. This is not a war or a fight. It's almost become so. What I see, people are very sensitive about this. Editors are very sensitive about this. We have two groups: MAFL versus NAFL. And see, this editorial says, MAFL versus NAFL. Let the contest begin. And they go on to write. Let us see how many articles come in favor of NAFL and how many are in favor of MAFL, and what do they have to say? This is no way to, decide what is right and what is wrong in science. That let the contest begin and let the best win. This is not an election. I think there's time for a new classification. You have fatty liver, and depends upon the alcohol intake, we break it down into NAFLD and alcoholic fatty liver. And again, NAFLD can then be diagnosed, subclassified into NAFLD-M or metabolism associated NAFLD-E or environmental stress related NAFLD-G, genetic factors in NAFLD, and so on. Charting the road ahead, we must recognize the vast heterogeneity of NAFLD across populations and the multiple pathways involved. We must launch collaborative efforts, bolster treatment arsenal, curb the pandemic. Intellectual exercise is the need of the hour, not semantic jugglery, as in Alice in Wonderland, the Queen of Hearts says, words mean what I want them to mean. Such an attitude can have no place in the world of science. We can't have muscle flexing in science. Reminds me of when I had been to St. Petersburg, and this is, well past midnight in St. Petersburg, and I was wondering, where is Leningrad? Leningrad, those picture postcards I saw when I was a child. And then suddenly I realized I was in Leningrad. When the communists came to power, they changed the name of Leningrad to St. Petersburg. And then when they were thrown out of power, again the people of that city voted for St. Petersburg, so the name Leningrad went away. This shouldn't happen. For me, the name change is not a time for Requiem, it's a time for Ruwali. Thank you.
Thank you, SP. And I thank all the speakers for excellent discussion. And I am sure there are many more questions, queries, and comments about NAFLD, but the time is over. So I think more and more discussion we will have in our next panel discussion, moderated by Professor Gurdas Chaudhary.
Should we start? Deepika, should we start?
Yes, I think Dr. Gurdas Chaudhary, please start.
Okay.
Should I just introduce the names of the people who are there in the as panelists?
Please.
So Dr. Gurdas Chaudhary is the moderator. He's attached. I'll just tell you the attachments. Panelists are Dr. Kaushal Madan, Dr. Samir Shah, Dr. Ajay Duseja, and Dr. Amrish Sahani. So Dr. Gurdas Chaudhary is Professor, Executive Director, Department of Gastroenterology and Hepatology for Fortis Memorial Research Institute in Gurgaon. And he's been the past professor and head of Department of SGPGI Lucknow. So he's going to moderate the entire session. Then Dr. Kaushal Madan is Principal Director and Head, Clinical Hepatology, Max Hospital, Saket, New Delhi. Dr. Samir Shah is Head, Department of Hepatology, Institute of Liver Diseases at the Global Hospital in Mumbai. And Dr. Amrish Sahani is Senior Consultant Gastroenterologist and Hepatologist in BLK Hospital, New Delhi. So I think we should start the session, Dr. Chaudhary.
Thank you so much. I think we'll start off where Dr. SP Singh left. So, there are some burning questions. So my first request for clarification would be with Dr. Samir Shah. He's a very senior, experienced hepatologist. which part of that elephant are you feeling at the moment as a blind man? You know, the proverbial blind man. So my question is a bit loaded in the sense that amongst the four speakers we heard today, I think Arun Sanyal started off by telling that, you know, the metabolic footprints of this disease are quite a lot. And, you know, almost many organs are involved. The heart is particularly vulnerable and so on and so forth. And then we very often revert back to that F2, F3, F4, you know, I mean, the obsession with fibrosis in the liver, the degree and so on and so forth. Can you help us to make some sense out of this?
I think, Gaur, you are absolutely right. What happens is that the patient comes to us either with a sonography report of fatty liver, then that becomes the primary concern of the patient and the referring doctor. If the patient is seen by us for elevated liver enzymes, then we find out what is the cause and ultimately land up with NAFLD as the cause. And obviously, if the patient is cirrhotic, then we know, because we have sort of looked at the patient as a total thing. Now, to come as far as treatment is concerned, you are absolutely right. Focusing just on the fatty liver component is not what is going to help the patient. I think we all need to know, and we are all aware that the components of the metabolic syndrome need to be identified: the diabetes, obesity, and triglycerides. And optimal treatment of that is going to yield more results than just looking at the fat alone. Second is, all of us gastroenterologists and hepatologists, we are aware that fibrosis is the key towards these as a risk factor for the adverse outcomes. So we need to identify fibrosis in this group of patients to see whether which of them are likely to progress. So to tell you that we looked at all our patients who were referred for NAFLD, and we evaluated all of them by MR elastography. 40% of these had less than 2.9 MRE score, which is normal. So 40% of the patients referred to us do not require anything further than just lifestyle modification and control of the risk factors. The rest, 60%, yes, they had F2, F3 fibrosis or F4, so they would require our focus. So this is the key as an answer to the question, that yes, the patient and the referring doctor may be obsessed by the fatty liver, and the patient may tell, my fatty liver on ultrasound became from grade 1 to grade 2 or grade 2 to grade 3. That is what they are obsessed with, but we need to look at the entire thing as a whole.
Thank you. Do you think we might inadvertently be perpetuating their obsession about the liver? I mean, let me put the question the other way around. I think the earlier data showed that about 20% of patients with fatty liver disease will ever develop cirrhosis, and clinical cirrhosis would be in a minority. Whereas we also heard from several other speakers that probably the majority of them die of cardiovascular events. So how do you think we should proceed in terms of the patient's interest rather than our interest? I mean, you have a very large experience where I gather you also sit with an endocrinologist, and you have a very comprehensive approach to it.
Surely. So I think to answer your question, number one, we should not unnecessarily make liver patients out of patients who have a metabolic syndrome, because as I said, 40% do not require our attention at all. What we have been doing now in our hospital, especially in the health checkups, is to ask them to do a FIB-4. So in a general health checkup with SGOT, SGPT, platelet and age, if the FIB-4 is less than 1, then we do not need to do anything further on them. Only if the FIB-4 is more than 1, we need to see them in detail. And if it is more than 1.3, then surely they need attention. So I think a FIB-4 will sort of stratify these patients very effectively, and we will not unnecessarily create liver patients where there is none.
Thank you so much, Samir. I move to Dr. Kaushal Madan. Dr. Kaushal, the literature keeps changing, and I believe its time is a factor, and also the place, as Dr. S.P. Singh very rightly said. So, the Western type may be somewhat different from Indian regional types. How important do you think, or how vulnerable do you think is the Indian heart in patients with non-alcoholic fatty liver disease?
Right. So I think a lot has been said and a lot has been written about the Indian metabolic profile. And we all know that Indians and especially Asians, even at a lower BMI, they have higher visceral fat, and therefore all complications which are associated with visceral fat, including the metabolic syndrome, the complications associated with metabolic syndrome, and also non-alcoholic fatty liver disease. And as you rightly said, the most common cause of mortality in these patients or significant morbidity is cardiovascular related. So if you identify a patient who has non-alcoholic fatty liver disease in our subcontinent, I think it's our duty. I'm not saying for the liver, but for the other metabolic complications, to identify those and risk stratify these patients for at least cardiovascular risk factors. So I think,
I mean, it's almost what you're suggesting is like what the endocrinologists do, that if somebody is diagnosed as a fresh case of type 2 diabetes, they would usually also ask for a urine microalbumin and maybe an ophthalmological examination for the fundus or something like that. So would you recommend that we put most of our newly diagnosed NAFLD patients through a cardiac assessment, or what is your suggestion?
right. So I would not go to the extent of doing a ophthalmological examination or a urine routine unless there are risk
that is for diabetics. I'm talking about fatty liver and heart.
Right. So I think as part of the Inasl NAFLD project, also we had come up with a basic minimum workup which should be done in these patients with regard to the metabolic risk factors, and this includes a workup for dyslipidemia, hypertension, presence of diabetes by getting a baseline HbA1c and fasting and PP blood sugars, and an ECG. And obviously, if you have these risk factors or multiple of these risk factors, then yes, a reference to an endocrinologist and a cardiologist should be done.
Thank you so much. Due to the paucity of time, I'm going a little quickly. Otherwise, I think each of these questions and comments could have been a topic of discussion between such eminent panelists, 4 of them. Can I move to Dr. Ambrish Sahni? Dr. Ambrish, welcome. I'm asking you this question because this talk was delivered a while ago by Dr. Ajay Duseja. So I thought it might be worthwhile getting your views. Are you there, Dr. Ambrish?
Yes, sir.
Hi. So, this combination therapy is always an attractive idea. I mean, after all, ever since tuberculosis combination therapy and HIV combination therapies, I mean, we know that, if properly combined, the treatment becomes more effective. The problem that seems to come in many disorders or diseases is that each pharmaceutical company that comes out with a product seems to be rather possessive and unwilling to kind of partner with others to get into combination trials. Of course, Ajay very rightly showed some preliminary data on some of the combinations. What are your thoughts on the subject?
Sir, if we see logically, the combination therapy offers an advantage over the monotherapy, as response rate over placebo may increase in combination therapy. But not in real life situation, but in trial situation, it involves combining the 4 arms. Each trial will have a 4 arm, which is itself a cumbersome situation. 2 for monotherapy, 1 for placebo, and 1 for a combination therapy. And then doing a pre-post biopsies of these patients and showing the response in a surrogate, like a biopsy response in these patients itself will take a 2-3 years time. And again, we will not be sure, even if the response is from 25 to, say, it increases up to 65%, then what will happen to the rest of 35%? What are the predictors of non-response, or the predictor of response in these patients will be more beneficial for the management of NAFLD patients. One. Second, if like in a trial shown by Dr. Duseja, ASK1 inhibitor has been shown to be ineffective alone. But combining that drug with the other drug, FXR agonist, and doing that trial, I think maybe a industry-driven thing. Because if a drug has been shown to be ineffective in a phase 2 trial, again using that same drug in a combination therapy may not make a sense. Third, there can be effect of heterogeneity in when the multiple drugs are combined together and used in the trial. This situation will not be in a real life situation. If I am dealing with a patient of NASH with F2, F3 fibrosis who needs treatment, and I am combining a drug and saying him, yes, there is 65% chance that you will respond, but not 35%. I will be more interested if I have certain markers or if I have signatures which tell us, yes, combine these two drugs will be effective in this certain patient and there will be a response. So what I think in future work should be done on assessing the markers of response or taking out the signatures which will tell us which patient requires which therapy, which combination of therapy. That will be, I think, better target of trials than taking certain drugs, combining them and doing the liver biopsy and showing the results.
Good, thank you so much. Actually, one of the problems with metabolic disorders, is that all the trials take a lot of time. I mean, unlike say hepatitis C, where you get a response within 3 months and in 6 months you know whether the virus is gone. Metabolic trials take a long time, and the graphs, as somebody very rightly showed, one of the 4 speakers, I mean, the bars are actually pretty dwarf type of ones. I mean, they don't look very tall and handsome. So it's always a bit of a problem, 30%, 40% response rate. But anyway, very interesting observation. May I move to Dr. Ajay Duseja? Dr. Duseja, you are the champion of pharmacotherapy in NAFLD. So if I might ask you this slightly provocative question, we seem to be comfortable in India with the idea that saroglitazar, a product developed by an Indian company, has a good safety profile and is reasonably effective in fatty liver disease and so on and so forth. In international circles, people don't seem to talk too much about it. I mean, at least the guidelines don't mention it yet and so on and so forth. Where do you think the hurdles are?
I think the hurdles, I feel, as you said, this is an Indian molecule patented molecule by an Indian company. So each country would have their own, ways of regulation or clearing the drugs or approving the drugs. Like in DCGI here, we have FDA in US, we have EMA in Europe. So obviously, I think the regulatory authorities look at, the kind of data which is there in their population, their country, before they, kind of give approval for drugs. I mean, we had this drug in India, say for almost 10 years for usage in diabetic dyslipidemia. So the real life experience was huge. And then was, this evidences 2 study, which was, the biopsy proven data from India, and then a lot of real life data. And based on that, the DCGI thought that yes, this required approval, fine enough. Now, the hurdles internationally would be that you need to have similar kind of studies to be done. Say, for example, in US, the last month or this year only, we had a publication in hepatology, which was a phase 2A study around 102 patients with saroglitazar, which has been published, which as a proof of concept have shown that it reduces MRPDFF, related steatosis, biochemistry, everything. And now they are going to phase 2B, and the plan is to do a phase 3 data there. So I think once they have a phase 3 data in their country, say in US, and they show a similar kind of improvement, and then obviously they would put this everything to FDA, and then I think the FDA would decide. So as I said, this is the regulatory thing. You need to have your own population based data. And similar kind of data, I don't know what's happening, but the Mexico is another country where this drug is available, and they had done usage of this drug. Not only they have again a phase 2 data, not only in NAFLD but also in PBC, the primary biliary cholangitis. The sero is being used. So I'm not sure whether it is still approved there. I think India is probably the only country, but I think the only hurdle the question you are asking is that, I mean, you have to come up to the expectations of the regulatory authorities. So you need to generate your own data. I mean, like we in India for hepatitis C drugs got a lot of waivers looking at the data which came from the Western group. So if the FDA looks like that and they kind of give waiver to this thing, that probably will not happen. So they would like to look at their phase 2B data now, then maybe phase 3 data, and then they will decide whether they need to approve or not.
So they need a lot of, I would say, investment to get large trials done in the US, because I think doing trials is pretty expensive. And that too, doing it in the United States with the Indian molecule could be quite a formidable.
If I'm right, I think the phase 2B trial has already started, and they are already in the pipeline. The phase 3 is also in the pipeline. So they're already looking into that.
Good, that's very encouraging. We move to our fifth question. This goes to Dr. Samir Shah. Samir, much of the discussions on NAFLD everywhere, in India, of course, in most conferences, it's on the different trials with different molecules. But only as a brief passing remark, initially we mentioned that the whole problem seems to stem from our diet and lifestyle. How do you respond to it? In the sense that, of course, we know that there is a natural barrier of people not quite adapting to, our recommendation that you must run 40 minutes a day and stuff like that. But where do you think the problems are, and how the problems can be solved, if at all we need to nip it at the root? Samir, you're probably mute. We can't hear you. Sorry.
Please unmute yourself, Dr. Shah.
Okay. So we recognized this issue long time back, and we have a liver nutritionist as part of our unit. So all our patients with NAFLD are assessed by a liver nutritionist, and we just sort of looked at our data over the last 100 patients. And we were very happy to note that if a liver nutritionist is assessing the nutrition and guiding and following up with the patient, 60% of our patients lost weight. 20%, 0 to 5% of their weight they lost, 20%, 5 to 10%, and 20% lost more than 10% of their weight. So 40% of our patients increased their weight despite us liver nutritionist, but 60% did well. And I think that is the only way out. Just by telling a patient you need to diet and exercise, it never happens. So actually all the placebo data in these studies, they are pretty good, because these are all studies where patients are looked after carefully. So if you look after your patient well by a dedicated liver nutritionist, you will achieve results. And we looked at our liver enzymes also. Even though the patients had not lost weight, the liver enzymes have improved. So I think it focus of a person who is dedicated to produce results, do produce results.
Do you think the recent performance in the Olympics could be a motivating factor? But we are pretty good at watching on television, but yes. Do we get down onto the field, or how do you recommend that we translate it into practice?
I think each one of us will have to have our own nutritionist to guide not only just fatty liver disease, but also the other liver disease, our cirrhotics, decompensated cirrhotics, we need to sort of put more time rather than just tell, okay, salt restricted high protein diet. I think that is what in a busy OPD we'll end up doing. But if you have a dedicated nutrition sort of focus program, it will definitely yield results in all aspects.
Thank you. I think we have run out of time, but if I get 2 or 3 more minutes, then the last question I'll finish. It's an important question.
Dr. Chaudhary, we've got 8 more minutes on the timer.
8?
Yes, we've got 8 minutes.
That's a huge amount. Deepika,
Yeah.
can you ask the audience if they have any questions? And, I'll put it across to my panelists. But the last question goes to Kaushal, and, obviously I'll throw it open to the others as well. The only person who seems very active in India, keeping a very fit figure and, full of energy, is Baba Ramdev. And you can't deny the fact that, he's full of energy and flexibility. And one has to give credit to the fact that he has popularized yoga quite a bit. Whatever else he did, I'm not touching on that, but that part. Now, scientifically, what do you think is the proof, or shall we say the standing of modern science on yoga as a means of encouraging people to manage fatty liver disease? Kaushal, what are your thoughts?
Sir, in terms of theory, I think we all know that use of muscles or toning of muscles, even if you are not able to lose weight, leads to improvement in the insulin sensitivity. So theoretically speaking, in whatever form you exercise, whether it's yoga or it's aerobics or it's weight training, it does help improve your insulin resistance and therefore the effect on hepatic steatosis. Now, in terms of evidence, I agree there is very little evidence, but mostly from our country, there have been a few studies, but mainly in diabetics. So there is a randomized control trial of about 37 women who have pre-diabetes or diabetes. And then they also looked at, which obviously is a non-robust way of looking at it. They looked at ultrasound evidence of improvement in fatty liver before and after yoga. And the main outcome which was significantly improved was the control of diabetes. The HbA1c and fasting blood sugar had come down. Similarly, they had another study of almost 900 prisoners where they had a yoga camp for 10 days and they demonstrated at the end of 10 days that there was an improvement in fasting blood sugar. The previous study was done over 3 months. This was for a shorter duration. So we do have evidence, but yes, we need to collect it more robustly and demonstrate its effect on the metabolic profile as well as robust measures of improvement in liver fat or liver fibrosis. So I think the first would be to show an impact on reduction in fat by MRI PDFF. So I think if we can demonstrate that, that would be the first important effect we would demonstrate with yoga.
I'll ask my other 3 panelists.
My last line is that we need to have more data.
Okay. I'll ask the other 3 panelists. This is one of the problems I face in clinic. So every time I tell this guy that, look, you need to lose weight. For this, you need to take a calorie restricted diet and you need to do aerobic or anaerobic exercise for 40 minutes. Immediately comes the counter question, but can I do yoga? Now, how do you respond to that kind of a question? What do you do, Ajay?
Yeah, I think, the lifestyle interventions, obviously, we all understand is the key for this lifestyle disease, what we are discussing today. I would personally feel that we have 2 sets of patients in the clinic. One would be, if you tell them to exercise, say jogging, running, swimming, cycling, or brisk walking, and they'll be happy. But then there would be a group of patients, those who are not able to, comply with, these kind of this thing, whatever issues, maybe cardiac issues, maybe your joint issues, osteoarthritis, whatever. So, then they will ask you this question that, can I do something? I can't walk much. I can't jog. I can't do this. What is good for me? So I think for them, yes, any kind of, resistance exercises, one which Kaushal said would be very, very good. But then, yes, this would be the group I personally feel I think you could add yoga onto them. And yes, as I said, the muscle toning would come in, the resistance exercises. I think this they would, not only would maybe they may burn some calories or not, but then at least if the muscle insulin sensitivity is improving and we are doing reduction in the reduction in insulin resistance at the muscle level also, I think the things would help. So I think I would feel that this would be for a group who's not able to, kind of do the aerobic exercises, or maybe some other, active lifestyle. I think for them, I would add it. Yes, I think for others also it can be added, but as Kaushal said, I think we don't really have good evidence for that.
Okay. So, I mean, you wouldn't expect a Swiss fellow to generate evidence on yoga, would you?
Obviously, we need to do that. Yeah. So
I think it would be particularly important for people like Samisha. I mean, in Bombay, where do you go jogging? Yeah? I mean, somebody would come, one of those bikes will come and pop you, I mean, bump you up. So what do you do with yoga questions, Samir? And
So
I'll
I ne-
put two
so I-
questions which the audience has asked. So after Samir.
So I never ask anybody to stop yoga. So I always tell them, yes, do continue yoga, but do 3 times a week. And the rest 3 days a week, do aerobic and resistance exercises. So I think then they have no answer left.
Amrish, what do you do?
Sir, if somebody asks me that yoga can be done or not, I explain them do Surya Namaskar, because this is one exercise which is a combination of both aerobic and isometric resistance exercises. This will lead to the weight loss of the patient, which has been proven. And a study has been going on, which is multi-centric, 2 centers from Kerala and 1 center from University of Nottingham, in NAFLD patient, which has been going on, and results will be out by, I think, 2022. So I specifically tell them to do Surya Namaskar if they ask me specifically. Otherwise, I tell them to continue with their aerobic and resistance training.
Thank you so much. If any of you have done Surya Namaskar, it actually really pushes up your heart rate, makes you sweat, and it's a real exercise. The only problem is that most people, when I ask them and they say they do yoga, I ask them, what do you do? So they do only the breathing part of it. And that's why the weight does not change and they remain just plump as ever.
And maybe the best asana many of people would say is the Shavasana. Just lie down and take rest, and many of them would fall asleep actually while doing the Shavasana. Yeah.
We have 2 questions from the audience. Let me put them across. So first question is, should we combine, I think Deepika.
Do you want me to read it out?
No, should we come? Yeah, go ahead, Deepika, please.
Dr. Sudhanshu Patwari has asked this question. Should we combine pharmacotherapy and endoscopic procedure like duodenal resurfacing for management of NASH? So anybody can take that question.
Okay, I think I can take it up. There was a paper which was presented, I think 2 years back in ASLD 2019, where they did show the advantage of the DMR, what we call the duodenal mucosal surfacing, as an endotherapy. Most likely, I think the group probably was diabetics, if I'm right, but then they did show improvement in the fatty liver disease also. But thereafter, I don't think that paper was published as a full paper. I'm not aware, at least. And then, so I think endotherapy as a part of control of metabolic complications, including obesity and diabetes, is coming up. But again, I think we need to have good randomized control trials before endotherapy is accepted as a modality for reduction in body weight or even for control of diabetes. The question that whether we need to go for a combination of pharmacotherapy with endotherapy, I think would be, a little far off, thinking. I think we probably have to first prove the role of endotherapy alone, and even we don't have good pharmacotherapy, and then obviously I think the combining these 2 modalities will come later. Yeah.
Thank you, Dr. Deseja.
But if I may cross question you on this, Ajay.
Yes, sir.
Basically, most of the studies have shown the benefit in fatty liver disease seems to occur with weight loss.
Absolutely.
Significant weight loss. And I think this semaglutide is probably the main new chip on the block. Am I right?
Absolutely.
The other ones, I mean, there is a little bit of tinkering with your cap values and, you know, your F4 to F3 or F3 to F2 types, but doesn't really have great impacts. I mean, after all, we have now seen quite a few international trials. Some of them have faltered and so on and so forth. And some, well, they haven't been adopted all over university. So is it the weight loss that we should be really bothered about? And if that be so, then do you think logically this endotherapy, be it a balloon or any kind of a therapy or a bariatric surgery, is a good option?
See, the endotherapy works probably beyond weight loss, and that has been shown, whether it is balloon or DMR or whether it is, you know, the duodenal switch or other things, you know, it controls your metabolic milieu. We know people believe that it's the duodenum which is the culprit in diabetes and the various other things. So one is obviously weight loss, and second is the kind of, you know, the interactions between different hormones which occurs, may it be ghrelin or may it be adiponectin or insulin. I think there also the endotherapy, you know, is really helpful. So weight loss plus, you know, the metabolic profile which improves. Yeah.
Great. One more question up there. Deepika, could you help us?
Yes. Dr. Harikumar Nair has asked this question, that we continue to engage in etiological control in most other etiologies, even after reaching F4 or clinically significant portal hypertension, aiming at delaying decompensation, reducing HCC risk and fibroregression, like in hepatitis B or AIH or Wilson's disease, but none of the combo trials seem to be targeting F4. Apart from Evion and he means vitamin E and metformin, do we have anything in pipeline for etiological control in compensated cirrhosis?
To all four.
Yes. You know, I think I did show one data, the Atlas trial, which is a combination of different, you know, drugs. I think 56% of, you know, population in that trial were cirrhotics, and the other, you know, 40% were F3. So, you know, this is a difficult group to, you know, treat, but then they had 56% and 20% had one stage reduction in fibrosis. So, which means coming from F4 to F3, I think though the, as I said, the statistical significance was not there, but people are now trying to look at the pharmacotherapy. And as you rightly said, vitamin E and metformin are two studies which are retrospective, which not really have shown the improvement in histology, but yes, have shown the improvement in clinical outcomes. Your requirement for transplant, your risk of decompensation, your risk of HCC, everything has been shown to improve when you're using these drugs. So clinical outcomes have been shown, and people are working on histology also in F4 here.
So probably, I mean, it's very difficult to prove with any trial a significant benefit unless you look at long-term clinical outcomes, as Ajay.
Absolutely, yeah.
I think that's the reason why there's a paucity of data in well-planned kind of studies, the way we find in the literature. But anyway, Samir, you had a point. I think you were coming forward to say something.
Sure. So semaglutide is also being looked into a new study which includes F4 fibrosis also. So after the silonsertib sort of disaster, the pharma companies were going away from F4, but I think they are again sort of re-looking, and semaglutide is one of them. There's a new study coming up for F4 also.
And that probably is also going to be a combo study. They will combo SAMA with other molecules. Yeah.
It's a triple drug.
Triple drug.
Yeah. I think we have finished our time, and it's my very pleasant duty to thank my brilliant panelists, you know, very knowledgeable, experienced people who have cleared many of our doubts, and I'm really grateful to each and every one of them. Over to you, Deepika.
Thank you, Dr. Chaudhary. I would like to thank all the speakers who took part in the NFLD symposium, Dr. Arun Sanyal, Dr. Ajay Duseja, Dr. Jasmohan Bajaj, and Dr. SP Sin for the brilliant talks. I think we've learned a lot more new things if we can't keep up with the, you know, new concepts which are coming up. And hopefully all the audience who've heard these have also benefited from these brilliant talks. I think we now close the NFLD symposium for tonight. Thank you for Inasl. Thank you, everyone.
Thank you. Bye-bye.
Thank you.
Thank you, everybody. I think Amrish has a message to Amrish.
Everyone, delegates, participants, speakers, moderators, panelists. And I will invite all of you for the next day session The highlights of next day sessions are in Hall A. There will be an oration on newer indications of liver transplantation by Dr. Mohammed Rela, followed by another oration of innovative therapies for most of the liver disease by Dr. Akbar, followed by case-based discussion on ascites in Hall A. Then there will be poster session in Hall B, followed by case-based discussion on liver transplantation. In Hall C, there will be a case-based discussion on DILI. So these are the tomorrow's highlights, and I welcome you all to join and make the Inasl day 2 also successful as you have done for the day 1. Thanks.
Dr. Chaudhary, thank you for moderating this brilliant discussion.
Thank you so much. Thank you.
I
Pleasure.
would
Thank
want to add one more session for tomorrow, that is plenary session. That's a very important session. The youngsters, as well as people above 40 would be presenting their original work and would be judged for that, and there'll be 2 prizes.
Wonderful.
Please join tomorrow.
Thank
Bye
you.
bye. Thank you. Bye bye. Bye.
Bye. Bye.
Good night.
Bye.
Thanks.
Yeah. Good night. Good night.
Good night.
Good night.
Akash, I think you can just...
हेलो
हाँ आकाश,
स्टॉप कर दूं?
या रिकॉर्डिंग्स वगैरह सब टेप करके रख लेना, है ना?
हाँ बिल्कुल बिल्कुल।